I have a question.
Okay.
When is it good to get hormone testing? I'm curious because I've never had hormone testing, but I have believed that I probably should for a long time.
Okay.
So I mean, they did a big discount on blood tests, so I ordered to do one. But to go in and actually do it, I don't know what a good time to go in to do it. Like, does it matter when in a monthly cycle you should do it, or and can you just like go get hormone tested, or and have the one testing matter, or do you have to keep getting them tested to see if they matter? I mean, there's just lots of questions with that. I don't know.
Right. Um, Good question. All right. So this is a good one. Hormone testing, when should we get it? And so I said, the Captain Obvious answer is when you suspect, when you're having suspected hormone symptoms, or you suspect hormone issues. But then you have to dial down to, well, is it a male or a female? If it's a female, do they have a menstrual cycle or not? And if you're going to get the testing done, what time of day should you do it, and over what time span, and what method? So those are the considerations for the doctor to make. I don't know that a layperson is going to know of those, or how to make those. But if we dive into those, first of all, time span, or let's go in reverse, method. So you could do blood, you could do saliva, you could do urine. Okay. And with all of those, you could do, over a 24-hour period. You could do it over a month period to collect the whole menstrual cycle, say, or you could do a spot shot. And typically the spot shot is blood. So right when they stab you with the needle, what is it? So, if we're measuring my testosterone and we did it in the blood, or you're looking at your estrogen, or any blood hormone, essentially is looking at what's the hormone level in the moment that the needle pierced your arm and drew the blood. And so that's typically how medicine does it, mainstream medicine does it. And that can be useful because there are certain markers we can only see in the blood. So of course, that's what we have to do. But that's only, again, a spot shot. That's a Polaroid picture. Right when they stabbed you, what was it? So it's possible to have a normal testosterone at the moment I was tested, or a normal progesterone at the moment I was tested. But over the whole day, over the 24-hour period of the day, I might be lab low. So we can be fooled by that Polaroid picture. Whereas over a 24-hour period, you can test 24-hour hormones with urine and or saliva. And a 24-hour collection is more of a video, right? Because it's the whole day. And there can be a circadian rhythm to these hormones. And so if you tested it in the morning in the blood and it looked good, but you collected the whole 24 hours and it was lab low, we know that the Polaroid picture fooled us into thinking we look good, whereas the video showed us we don't. So an example of that would be if I was going wakeboarding and I hit the wake and jumped on my wakeboard, and you snapped a Polaroid picture of me in the moment that I was in the air, I could look really cool, and you could share that on Facebook and say, look at what a great wakeboarder Dr. B is. But then right next to you, someone was videoing me, and I actually, when I came down to land that, I crashed, and they posted the video in the comments on your post and said, actually, he stinks, watch this video, right? And the video gives more information, so we can do more with that. And then the over the month testing is, can be urine or saliva. And you could actually even do blood too, if you were going to really want to be a pincushion. But a full month testing looking at a menstrual cycle would be collecting urine and saliva, and then blood if you want to get stabbed 11 times, 11 times over the month to map out what are your hormones at certain times of the month. So in the follicular phase of your menstrual cycle, what are they? Around ovulation, what are they? And then in the luteal phase, what are they? And having that information shows us an entire menstrual cycle and helps us understand, you know, is the curve of estrogen throughout the month where it should be? Is the curve of progesterone where it should be? Did you ovulate and get a, you know, the spike when you want to? What do you know, what do FSH and LH, or is there an issue there? So it depends on what we want to know and how in depth we want to go. So usually you start with blood, and if that's normal, you know, conventional medical doctor would say, oh, your blood hormone, your hormones are normal. We got nothing for you, you know. And if you leave believing that, then you might be okay. But if you leave believing that and then the hormone symptoms persist, you might want to look at a 24-hour test to say, okay, are we being fooled by the Polaroid picture? It's also possible that the blood, if you do the blood test at the wrong time of day, you might get wrong results. Like, for example, a testosterone in the morning is going to look different than a testosterone in the evening. So what are we trying to see, and are we getting an accurate number? So if we only ran it in the morning, it might look robust, and we tell the person that their testosterone's normal, but the guy's coming in complaining of an afternoon crash, and we didn't even test it at the time of the symptoms. Well, that's not the best information for us. A non-cycling female or a cycling female, these matter because what's normal, or the normal ranges, are going to be different depending on where you are. You know, if you're a cycling female, then what we expect to see from an estrogen progesterone standpoint is going to be different than if you're a non-cycling female. Whether the non-cycling is because you are actually postmenopausal by age, and like if you're physiologically postmenopausal versus say you've had a full hysterectomy that included the ovaries, now you're surgically postmenopausal, even, you know, even if you're 28. So again, understanding that is important as well. And if you're a cycling female, then we want to, there's a certain time that we want to see to catch your marker. So if you are doing blood, then, you know, if your medical doctor wants to run your hormones in the blood, you need to know where you are in your cycle. Okay, because when you get the results, the normal range is going to give you a range for follicular phase, and it's going to give you a range for ovulation. It's going to give you a range for luteal phase. So if, when I review medical records on women and there's blood hormone testing in their medical records, if I don't know where they were in their menstrual cycle at the time of that blood draw, I don't know if they're normal or not, unless they're so abnormal that they're out of range for all three of those ranges, right? So always make sure if you're getting blood hormones as a female, you know where you are in your menstrual cycle, what day you're on, if you are a cycling female. Now, if you're doing, and the same applies for urine or saliva on that, if it's a single collection. If you're doing the 24-hour collection, then ideal would be to collect between day 19 and 21 of your cycle, because then we know we have a nice shot of where all the hormones should be at that point in the cycle. And we can see, okay, here's what an ideal cycle looks like in terms of hormone levels and at day 19, say, and here's where yours were at day 19. So if they're not ideal and we know the day, then we can take action based on which hormone was not ideal. You know, and then when we want to retest to see, have you made improvements, we can retest on day 19 of the cycle that, you know, the closest cycle to the time that we're retesting. So these are things to consider. Where does that take your brain?
Well, I have a question or comment. Now, for women taking birth control or hormone replacement therapy, this kind of complicates this even further, correct?
Yes. Yeah, any sort of exogenous hormone is going to change things because, you know, you're taking it. So that's going to complicate where we're at. So bioidentical hormones are going to, you know, show up. Synthetic hormones, synthetic hormones, they say don't show up. So it depends. But the synthetic hormones will impact your body's production, because it's kind of like if I were to take testosterone injections, right? I'm providing it exogenously. So over time, my brain stops telling my gonads, hey, make testosterone, because he's getting it from the outside. So it's kind of like a hormonal welfare check. If I'm going to get it from the outside, say you give me a check for $10,000 a month for some amount of time, and then you stop the check and you say, hey, go work. I'm not gonna want to work because I got used to getting the check. Same idea. If I'm giving myself testosterone exogenously and then we pull it out and we're like, hey, gonads, go to work, they're gonna be like, what? We've been shut down for so long, you know, we can't. So even if it's synthetic hormone that you're taking, and if it's not showing up on the labs, it still impacts your natural production. And so that could be tricky, because if it's down regulating your hormone production because you're providing it from the outside, is that down regulation just, is it low because of expected down regulation, or is it low in addition to? Does that make sense?
I have a question.
Okay.
I have a question. What is your opinion on postmenopausal hormone replacement? Do you feel like it's necessary? Do you feel like it's dangerous in some, as far as cancer risk? Just interested in your opinion.
Yeah, I mean, the cancer risk piece is going to be individualized. You know, if you're doing postmenopausal hormone replacement on a female that, say, is estrogen positive and HER2 positive, has these different positive gene susceptibilities to estrogen sensitive breast cancer, then yeah, that might be dangerous. But there's also a time and place for it. So if you ruled those things out, and someone, you know, isn't making hormone, and you've ruled out, you know, functional causes of why they might not be, or why their hormones might be messed up, then some bioidentical hormone replacement might be prudent and necessary. But before you go taking hormones, let's say before you take hormones, there's, say, the 4 pillars that you want to investigate from a physiology standpoint, that if one or more of these things are messed up, then, you know, taking hormones might help your symptoms, but you're leaving these underlying causes. So one is going to be blood sugar dysfunction, needs to be addressed. Inflammation needs to be addressed. Liver issues needs to be addressed, and gut issues need to be addressed. Why blood sugar? Well, because insulin surges, if you don't handle your blood sugar well, if you're having insulin surges promote dysfunction in hormones. In a male, insulin surges promote increased function of an enzyme called aromatase, and aromatase is what converts testosterone to estrogen. So if you've got a guy who's insulin resistant and he's having low T symptoms, and you just go to a T clinic and you get testosterone, but that insulin resistance is driving increased conversion of testosterone to estrogen, the testosterone from the hormone clinic may drive that male female faster because they're giving him testosterone, but his body's converting it to estrogen more inappropriately. So yeah, I took estrogen or testosterone and I don't feel any better, and I'm still gaining belly fat and man boobs, which is called gynecomastia, and I'm crying at Hallmark commercials and things like that. They didn't address the cause, so you need to address the insulin. Inflammation, if you're systemically inflamed, that's going to be a tiger, right? That's going to drive cortisol, epinephrine, the HPA axis. And when you're stressed, you suppress sex hormone function, because reproducing when a tiger's chasing you doesn't lead to survival, right? So sex hormones in the environment of chronic stress, chronic inflammation are not a priority for survival. And that's what the stress response of our physiology is set up for, is to help you survive. So again, if you're high stressed and you go take testosterone, it might make you feel better in the short term, or estrogen in a female, whatever we're talking about, might make the symptoms better in the short term. But if you leave the tigers, you're going to need more and more of the hormone, and you're still not addressing the issue. And like we talked about earlier with the free paycheck scenario, if you're doing that for too long, you might not be able to eliminate the tiger and go back to normal hormone production. If it's liver, the liver is our major detox organ. So the liver, it takes 2 phases to eliminate hormones. Hormones, your estrogen, your testosterone, your progesterone, these are all fat soluble. These are all fat hormones. To get rid of them, we have to turn them into water. Okay. So for the liver to do that, it takes 2 steps. So you take estrogen, for example. Estradiol is a fat soluble hormone. The first step 1, phase 1, turns it into an intermediate. And then you need phase 2 to turn it into water soluble. And then you can excrete it out your urine, your feces, or your sweat. So if you have any issue with liver, phase 1 or phase 2 detoxification, this may not happen. Phase 1 is heavy on hydroxylation, and phase 2 is heavy on methylation. So if you have any issue with hydroxylation or methylation, which include various genes and various nutrients like B vitamins and things like that, then you may not clear hormones well, and you may have hormonal imbalance. And then the gut, if you have gut dysbiosis, or imbalance of good bugs or bad bugs, there's certain bugs that produce an enzyme called beta-glucuronidase. And it's a big word, but why that's important is because if they produce that enzyme goes over here to the intermediate step, and it can take this phase 1 intermediate and turn it back into the parent. And so these intermediates sometimes are more toxic than the parent, than the estradiol. So if we go back to step 3, where if there's a liver issue and we have a buildup of the intermediates because of a methylation issue in phase 2, now we've got more intermediates building up, and that can increase cancer risk. That can increase inflammation and those things. Well, if we have a gut issue from bugs producing too much beta-glucuronidase, now we're taking estrogen, turning it into an intermediate, but this enzyme is turning it back into estrogen. So now a woman or a man could be estrogen dominant, not because they're producing too much estrogen, but because their gut is unhealthy. They've got bad bugs in there producing too much of this. Okay. So again, if you just take a hormone and don't look at all this stuff, you're at best creating a band-aid, and at worst, driving things much more off kilter.
So when would you consider hormone testing? Like what symptoms and signs would you look, consider that?
Very good question.
Yeah. Menstrual cycle issues, say you don't have a cycle, or say you have an irregular cycle, or say there's a say you're a male or female with hormonal symptoms that these other areas have been taken care of, or at least been investigated and are being worked on and optimized, and those hormonal symptoms are persisting, then maybe you look more specifically at those things. At the hormones. Yeah, I mean, you can run hormone testing anytime. It's just the reason I don't run it anytime is because if these other areas over here, these 4 pillars that haven't ever been investigated or addressed, then chasing the hormones is putting the cart in front of the horse. You might be able to knock down the hormone domino by dealing with the insulin, so to speak, as an example.
I actually just emailed you like 2 days ago, I think.
Oh, I haven't seen it yet. Sorry. My goal is to get to it today or tomorrow, but go ahead.
That I kind of think that I have PMDD. And I want to get tested for it. And I was going to ask, like, what does that testing look like when you don't have a regular cycle?
Yeah, so good question. You guys are awesome. All right. So if we go back up here, if we go back over here, okay, and we talked about if we're doing, whether or not you're doing single blood test or you're doing the 24-hour test, like I said, you need to know where you are, okay? And so if you have a cycle and you have an app where you're tracking your cycle, or you're just, you're a good tracker, if you know where you are, then cool. We can decide, we can either run it right away knowing what day you were in, or if we're doing the 24-hour testing, getting to day 19 to 21 would be ideal. What if you don't have a cycle, or it's irregular? Well, then what you can do is you can use what are called ovulation predictor strips. Okay, and you can get these on Amazon or at Walgreens or CVS or whatever. And these are just strips that you urinate on once a day, and you're looking, if they're positive, then you're ovulating. And when you're ovulating, if your cycle, if you know the average length of your cycle, for example, if you know your cycle is 28 days and ovulation is positive, then you're at day 14. So then you can count forward to find day 19 to 21 and test in that window. If you don't have a menstrual cycle, if you don't have a menstrual cycle, or even if you do, I recommend everyone use the ovulation predictor strip so we can be as confident as possible that we found ovulation and then counted forward to the day we wanted. Life isn't always perfect. I've had multiple patients that don't have a cycle, and they go through a month or 2 of the or 3 of the ovulation predictor strips and never get a solid positive. Well, then we just have to, test. At that point, we did our best to get as dialed in as we could, and we couldn't find it. So then you test when it's convenient for you.
Okay. Well, whenever you get to my email, I guess we can figure it out, because I know we had talked about, you said something about like an 6 to 8 week iron panel.
Yeah. So iron levels are a key issue in PMDD, which is premenstrual dystrophic disorder, for those who don't know. And I've made videos on this in the past, but if you have high iron, that high iron can drive the PMDD and drive anxiety and things we've discussed in other videos that I'll link to here. But so to see that, I run the 6 or 8 weeks of serial iron tests to follow a woman through 2 cycles to be able to say, okay, if we run if say we sent you to the lab every Monday to get your iron test drawn, we did every Monday for 6 to 8 weeks, then we just went through 1.5, 2 cycles and saw how your iron levels changed throughout your cycle. Why is that important? Well, I've had patients that have PMDD, but their iron's only lab high during certain weeks of their cycle and is actually lab low other weeks of their cycle. So that helps us dial in, okay, if you know what week you're in your cycle, then some weeks we have to dose you with iron and some weeks we don't. And in figuring that out for people, it helps even out their iron status and even out their mood and their cycle experience.
Okay. I'm definitely interested.
Yeah. And so you would do the iron in, you do the iron at the same time as running that, say, full month cycle test. So we can see, okay, here's where she was in her hormone levels next to her iron levels. So we can map out that cycle. And so again, if you're not sure where you are in a cycle, then that gets more complicated and we can talk about that one-on-one, but that's kind of the idea.
Okay, yeah, thank you.
Mm-hmm.
Can magnesium deficiency also kind of contribute to some of the symptoms of that?
Yep.
Okay.
Yep.
And like 70% of people are magnesium deficiency.
Yeah, a high amount, yes. Yeah, so magnesium's part of 300 different enzymatic reactions in the body, so it's likely contributing to that and many other things in us. But yeah, specific to mood, cognition, anxiety, depression, migraine, brain inflammation in general, magnesium is a big player in that because it plugs the NMDA receptor. And that's a big nerdy term, but I've made a video on this before called the topic called excitotoxicity, and I'll link to it here. But excitotoxicity is essentially inflammation and oxidative stress in the brain leads to neurons blowing up and too much NMDA receptor activity and leads to anxiety, depression, whatever it is. Well, that NMDA receptor can be plugged by magnesium and by glycine. So that's why for those people, magnesium glycinate is the best form, because you're getting magnesium and glycine in the same pill, two things that plug that receptor. So two things that can help with your anxiety and or depression. Anxiety and depression may also be contributed to in certain people by poor circulation or poor blood supply to the head. Well, if you can't dilate your arteries to get blood there, you're going to get less blood there if they stay constricted. Well, magnesium's key for smooth muscle relaxation and for skeletal muscle relaxation. So again, it helps with things like blood pressure and circulation and nutrient delivery, lots of other things. It's important over here in the liver detoxification of hormones. It's important for lots and lots of things.
So just a general question with the magnesium, like everything has a warning label.
Mm-hmm.
And so is it important that we check with you to know which magnesium we individually should be taking, or is that just a general cover their butt thing and magnesium's okay to take? Or, I mean,
well, magnesium, go ahead.
Well, I just bought some magnesium 3-8 and then was reading the back and it said, make sure you check with your doctor before you take it. So I was going to email you.
Yeah. Well, that's a blanket term on all supplements. So that's just a CYA kind of liability term is, check with your doctor, because if you go take it and hurt yourself and sue them, they can say, well, we told you to check with your doctor first because we don't know anything about you, right? That's why a lot of them say take one capsule a day. And you're like, hey, would you please mute yourself if you're not talking? That's why they say take one capsule a day, because again, they don't know who's buying it. So they make the dose, small. And you might say one capsule a day, that's not a therapeutic dose. Well, yeah, they don't know what a therapeutic dose would be for you as an individual. So they have to just blanket cover their butt. So yeah, if we spoke, you might need a different magnesium than the next person. And there's lots of different forms, but in general, like Sue said, if a majority of the US population is deficient in magnesium, and they are, that's been published multiple times, then in general, magnesium is needed. And magnesium is very safe to take. Most common symptom, if you take too much, especially too much at once, is going to be a laxative effect and diarrhea. So if you do that, if that occurs, you just look at how much did I take and step it down, maybe cut it in half from there. And you could take the same dose in 2 separate doses spread out in the day and probably not have diarrhea. So it's kind of like vitamin C. You can take too much vitamin C at 1 dose, it'll cause diarrhea. Doesn't necessarily mean that's too much for you for the whole day. It's just too much for you at one time.
And different forms of magnesium do help with different symptoms.
Yes.
And also different absorption rates.
Yep.
So again, talk to your doctor about what his form is best for you.
Yeah, exactly. And so the magnesium threonate or the magnesium citrate or the magnesium malate or glycinate or succinate or oxide, there's a bunch of them. It's the second word that is different. So the magnesium's the magnesium, but the second word is kind of the other potentially therapeutic thing that's piggybacking on the magnesium to get in your body. So like I explained with the excitotoxicity earlier, the glycinate and magnesium, the glycine and magnesium glycinate does its own thing. It helps plug the NMDA receptor, but glycine's an amino acid we need to make glutathione. We need it for connective tissue health. It does a lot of different things. Threonate, threonine helps with calming the brain and decreasing anxiety and maybe helping you go to sleep. So, pairing that with magnesium, a lot of people take that who need help with sleep and anti-anxiety. Magnesium, citrate might be useful in helping you if you're constipated. Magnesium malate is useful for fibromyalgia and pain. So there's depends on what, who's in front of me, who's asking the question, what are the goals.